trainees and fellow surgeons. Welcome to another session in our education series. Today, we are unraveling the mysteries of IgG4-related gallbladder disease, a fascinating topic with increasing significance in the medical field. So, this will be the fourth video in thick wall gallbladder series, and I hope you have already watched the first three parts and other videos in our gallbladder cancer series. If not, do watch them now to have a better perspective. And for exclusive premium access to the HD content, please download the app or join the channel membership. The link for everything is given in description and pinned comments. So before we set the ball rolling, I want to share a small case scenario. So, we had this young executive who was diagnosed with acute autoimmune pancreatitis and already evaluated in a big corporate hospital, started on corticosteroids, and later on he presented to us for a second opinion 3-4 months later, and when we re-evaluated, the patient was already metastatic. So, we will give reference to this patient and other case scenario that we are discussing to have a better understanding. So friends, for the ease of understanding, whatever the case scenario we give you, these are a real time, real life case scenario. We try to keep it as close to the reality as possible so that you understand the theoretical and practical aspect of these discussions better. This was a 34-year-old lady with no known comorbidity. She had history of fatty dyspepsia, a loss of weight, which was undocumented for last 1 year and 4 months. There was no other positive history, and a patient was referred to us after a failed attempt of lab converted to open cholecystectomy with suspicion of carcinoma gallbladder. A general physical examination and a systemic examination was unremarkable except the cocker incision with the midline extension, which was basically after the previous surgery. So we evaluated the investigation which were already done, and her ultrasound revealed asymmetrical GB wall thickening infiltrating a liver with cholelithiasis. Her CCT was suggestive of asymmetrical thickening of fundus and body, which was again infiltrating liver. There was no other positive finding, no ascites, no evidence of any metastatic disease. So these are the cross-sectional imaging of the same patient, in which you can very well appreciate that the gallbladder is replaced by this heterogeneous enhancing, hypoenhancing mass, which is replacing the whole GB and infiltration into the basically liver. The vascular anatomy was well preserved. There was no infiltration of the portal vein or the hepatic artery, which is very well delineated in these cross-sectional imagings. Based upon the finding of previous surgery and these imaging finding, we planned this patient for extended cholecystectomy, and we also did CBD exploration because there was a stone palpable in the CBD and stone clearance was done. So there was no ascites or any deposit. Dense adhesion between gallbladder, duodenum and hepatic flexure were present, which were carefully and diligently cleared. There were multiple enlarged lymph nodes of station 8, 9, 12A, 12B, 12P, 13 and 16B. And gallbladder was replaced by the hard mass as was evident in the CT scan. There was a stone in the CBD which was cleared with cholecystectomy with primary closure. We did liver section, that was anatomical segment 4B and 5 section. And before proceeding, we did aortic cable lymph node sampling with frozen section analysis. And after resection, we also sent the cystic duct margin for frozen section. There was no evidence of malignancy in either of them. These are the intraoperative pics. Here you can very well appreciate that gallbladder is replaced by this heterogeneous mass, and it is basically replacing the basically occupying whole of the GB fossa. And upper right panel picture is of the cauterization and aortocable lymph node sampling, which is of course is the first step after we have decided for the extended cholecystectomy. And regarding this cauterization and lymph node station, we have covered in detail. There are video available in our this cancer of the stomach series and gallbladder cancer series, do check them out. So the we completed the lymph node dissection, completed all the template, all the vascular structures are basically looped. This large lymph node at station 12A has been highlighted. The common hepatic artery, proper hepatic artery, GDA, portal vein, CVD, all delineated very well. And this anatomical segment 4B and 5 section in the lower panel. So this is the cut open specimen after the extended this cholecystectomy, multiple stones, this thickened gallbladder wall and unhealthy looking mucosa, but we could not find any growth per se. Patient had uneventful recovery except he had this minor bile leak of 30 to 40 ml per day, which eventually settled, and we removed the drain on 10th day and there was no other issue. So the final HPR, there was no evidence of malignancy. There were features suggestive of IgG4-related gallbladder disease, and we will discuss more about this, and that is the topic for discussion of this video. So friends, it is a very important topic for you guys because in the present era of technological advances and this chat GPT era, I mean, there will be chances that the attendants or the patient will question you about the diagnosis, like you have diagnosed a case of gallbladder cancer. So the patient may ask, look doctor, whether I am suffering from IgG4-related disease because it is one of the differential, so that I may not be getting over treatment. So I mean, for answering all those questions, stay tuned till the end of this video. Friends, this is a relatively recently diagnosed, I think, and the first description of IgG4-related disease was in 2003. So there is an intense infiltration of various organs by IgG4 positive plasma cell. The disease can affect multiple organs, including the pancreas, liver, bile duct, salivary glands, and gallbladder. First, there is an infiltration of the organs by plasma cells which are IgG4 positive, and that is the IgG4 entity. This is a unique antibody IgG4, this is a subclass, and the clinical presentation is variable, can be vague. And as we are learning more about this, there are new presentation being reported and it closely resembles malignancy. So recognizing this entity is important, and as I said in the starting of this video, that we had this patient who was diagnosed with autoimmune pancreatitis, started on steroids, later on presented with metastatic head of the pancreas cancer. As I said, it was first reported in 2003 in IgG4-RD's related disease, IgG4-related disease. This is the abbreviation I have used in this video. So first it was described in context with this type 1 autoimmune pancreatitis, that is closing pancreatitis. Now it is called type 1 autoimmune pancreatitis with extrapancreatic manifestation. So pathological findings, basically pathological diagnosis, represent the cornerstone for a definitive diagnosis of IgG4-related disease. The exact incidence, prevalence are not known, data is evolving. The recognition remains low because even the treating physicians are not very well aware of this disease, and true estimation of prevalence remains elusive. The studies of autoimmune pancreatitis, that's closing pancreatitis, are conducted mainly in Japan, and the prevalence reported is 0.8 cases per lakh population per year, and 6% of total cases of chronic pancreatitis. Majority of the patients are men. This is basically male dominated and older age, more than 50. Male to female ratio is 4:1, and it has been reported low also, basically in some series. And the prevalence data for other organs, so we have data on this pancreatitis, but the other organ involvement is not very well characterized. The pathophysiology behind is there is a raised or elevated levels of IgG4 immunoglobulins in the blood, and there is an infiltration of the affected tissue by the IgG4 positive plasma cells, but the exact cause, etiology related to this disease is not very well understood. In different series, the reported organ involvement is variable, but the most common organ involved is pancreas, and the gallbladder involvement is less than 5% or approximately 5%. So as far as the clinical presentation is concerned, there are no specific telltale symptoms or signs which will help you to diagnose. So it can be subacute, non-specific complaints, weight loss, organ-specific complaints like maybe cholecystitis, pancreatitis. Classical finding that there is a tumor-effective lesion in at least one organ. So tumor-effective, it's like a tumor. So disease can develop over years. So it can have a indolent course, slowly creeping in and adding new organs one at a time. So first then pancreas, then maybe salivary gland, then gallbladder, or so on. In a study by Chen et al., the mean number of organs involved was 3 plus minus 1.6 at the time of diagnosis. Whenever we are talking about IgG4 disease, the malignancy will remain the first and the most important diagnosis which we have to rule out. And other diagnoses can be multicentric, Castleman disease, granulomatosis with polyangiitis, Sjogren disease, eosinophilic granulomatosis with polyangiitis, and sarcoidosis. So all the autoimmune disease basically can be in the ambit of this differential diagnosis. And friend, as we are understanding more, this can be this Sjogren disease, the sarcoidosis, or granulomatosis with polyangiitis. These all can be basically variable, different manifestation of the same disease spectrum, that is IgG4. And as we are learning more, you will have a better understanding. If you have any questions, then you can connect with us through the comment section on our YouTube channel, or through the chat option available on our app. Friends, we will keep unraveling the mysteries for you guys, one insight at a time, for a brighter, healthier future. Happy learning, and may your surgical journey be filled with discovery and fulfillment. And for a better learning experience, exclusive access to our content, download the app or join channel membership. Link for everything is given in description. So keep pushing, stay focused, and let your resilience shine. Your path is a story of strength and growth. Thank you very much. Happy learning.